All right, let's jump right in. If you're a medical trainee, you have absolutely seen this before. A patient's gastrin level comes back high, and you're kind of left scratching your head thinking, okay, now what? Well, today we are going to build a rock-solid clinical framework for that exact situation, taking you all the way from that one confusing lab value to a confident diagnosis.
So, here's our game plan. We're going to tackle this in 5 clean steps. First, we'll unpack that initial high gastrin puzzle. Then, we'll sort through the 2 major types of causes. After that, we'll zero in on the single most important test you need to order. From there, we'll hunt down that must-not-miss diagnosis of Zollinger-Ellison syndrome. And finally, we'll wrap it all up with a nice high-yield summary. It's a clear path forward.
Okay, so picture this. You're on rounds, you're clicking through the labs, and there it is, hypergastrinemia. That one little finding kicks off a whole diagnostic journey that can go down 2 totally different roads. One path is super common and, honestly, kind of expected. The other, it's rare, but it's one you absolutely cannot afford to miss.
This is it. This is the question that hits you in clinic or on the wards. So, where do we even begin? Well, the first step isn't ordering another test, it's actually just taking a second to remember what gastrin is supposed to be doing in the first place. So let's get on the same page super quick. Hypergastrinemia is just a fancy term for too much gastrin floating around in the blood. And what's gastrin's main job? It's the hormone that yells at the stomach, hey, make more acid. And that simple fact right there is the key to solving this entire puzzle.
And here we go. This is the big idea, the fundamental fork in the road. The entire list of causes for a high gastrin level splits neatly into these 2 buckets. Is it appropriate? Meaning, is the body doing the right thing, trying to crank up gastrin because stomach acid is too low? Or is it inappropriate? Is something just pumping out gastrin for no good reason, leading to dangerously high acid levels? That's the whole game.
All right, so now that we have that framework in our heads, let's put it to use. We're going to look at the actual medical conditions that fall into each of these 2 categories, the appropriate ones and the inappropriate ones.
So this table pretty much lays out the whole differential. But look, the most important thing to see here is that the column on the left, appropriate, is full of the common stuff, especially acid-suppressing drugs like PPIs that cause low stomach acid. The column on the right, inappropriate, that's where the zebras live. The rarer, more dangerous causes like Zollinger-Ellison syndrome, where the acid is already high or normal.
So listen up, because this is probably the most important clinical pearl of this entire explainer. Before you even think about ordering another expensive test, the very first thing you do is check the patient's medication list. Are they on a PPI or an H2 blocker? Because that is by far the most common reason you're going to see a high gastrin level. It's your number 1 high-yield first step always.
Okay, so you did your homework, you checked the med list, and your patient is not on a PPI. So what's the next move? This brings us to the one critical test that is going to tell us which of those 2 paths we're going down. Let's just pause for a second and think back to the physiology. If the big difference between our 2 buckets is the amount of stomach acid, what's the most direct test you could possibly order to figure that out? You got it. You measure the gastric pH. It is that simple. This single test is the fork in the road. If the pH is high, meaning low acid, that confirms it's an appropriate response. But if that pH is low, meaning high acid, in the face of an already high gastrin, whoa, that is a massive red flag, and it points us straight toward that inappropriate category.
So once you've figured out that you're dealing with an inappropriate hypergastrinemia, you've got high gastrin plus high acid, now you have to go on the hunt for the zebra, that must-not-miss diagnosis, Zollinger-Ellison syndrome.
Let's be really clear about what we're looking for here. ZES is caused by a tumor called the gastrinoma, and this tumor is just pumping out insane amounts of gastrin. All that gastrin tells the stomach to make a ton of acid, which then leads to really severe ulcers and bad diarrhea. It's a classic diagnosis for your boards, for sure, but you have to be able to spot it in the real world too.
Now, the good news is that sometimes making the diagnosis is a total slam dunk. Here's the most direct path. First, you've already made sure the patient is off PPIs. Next, you look at that gastrin level. Is it just ridiculously high, like more than 10 times the upper limit of normal? If it is, all you have to do is check the gastric pH. And if that pH is low, you're done. That's SACS. Diagnosis confirmed.
But of course, medicine is rarely that easy, right? This is the much more common scenario you're going to face. The gastrin is definitely high, the pH is low, but that gastrin level just isn't in that slam dunk territory. So, how do you confirm the diagnosis then?
And the answer is the secretin stimulation test. Here's the deal. In a normal person, if you give them secretin, it actually tells their body to make less gastrin. But, and this is the key, in a patient with a gastrinoma, secretin does the exact opposite. It causes a paradoxical, massive surge in gastrin. This test is the definitive way you lock in the diagnosis in those trickier, borderline cases.
Okay, we have walked the entire path. We started with a single lab value, and we ended with a definitive diagnosis. So now, let's boil it all down into a super concise summary, everything you need to know for your exams and, more importantly, for your patients.
So let's nail this down one last time. It all hinges on that one big question. Is the high gastrin appropriate for low acid or inappropriate because acid is already high? To figure it out, step 1, always check for PPIs. Step 2, measure the gastric pH. If you find yourself on that inappropriate path, a crazy high gastrin level plus a low pH confirms ZES on the spot. If it's more of a borderline case, you use the secretin stimulation test to lock in that must-not-miss diagnosis.
So we'll end on this thought. You know, the workup for hypergastrinemia can seem really complex and intimidating on the surface, but as we've just seen, it all comes back to one simple physiological principle. What does gastrin do to acid? So next time you're faced with a tough diagnostic puzzle, just take a breath and remember to ask yourself, what's the physiology? What is the body supposed to be doing right now? That question can often unlock the entire thing.